The following podcast is part of a certified educational activity titled Playing the Right Sequence in mCRC, Practical Strategies for Integrating Multi-Kinase Inhibitors in Later Lines of Therapy. Access the entire activity and complete the post-test at peerview.com/WEP860. Downloadable slides and practice aids are also available.
Well, hello and welcome to this educational session, Playing the Right Sequence in Metastatic Colorectal Cancer. My name is Dr. Bekaii-Saab from the Mayo Clinic in Phoenix, Arizona, and I will be discussing practical strategies for integrating multi-kinase inhibitors in later lines of treatment. Let's begin with our educational goals for today. Our goals for today include the need to augment your knowledge on the latest evidence and guideline recommendations for optimal tyrosine kinase inhibitor approaches in metastatic colorectal cancer, enhancing your skills to formulate individualized sequential treatment plans that consider the latest clinical evidence and patient-specific factors, and then equip you with strategies to address practical aspects of care with tyrosine kinase inhibitors, including management, treatment-related adverse events, dosing consideration, and shared decision-making with the patients. The first module will focus on real-world solutions to address unmet needs, collaborating to effectively treat metastatic colorectal cancer. Why are we here? So, exploring unmet needs in advanced metastatic colorectal cancer. So, when we think about patients with metastatic colorectal cancer, of all the patients who receive first-line, about 3 out of 4 will receive second-line treatment, and then 2/3 will receive third-line treatment, and less than half of the patients will receive fourth-line treatment. Now, why is this important? Because we know that at least for patients who are eligible for treatment, exposing them to the whole gamut of available therapies improves survival significantly. Now, recycling of chemotherapy and biologics in the second and subsequent line settings is common and occurs more frequently than switching to a drug regimen with an alternative mechanism of action, which unfortunately doesn't make as much sense, but has become common practice in some instances. Now, the expectations of the later line focus on patient preference, tolerability, and quality of life, understandably. Various dosing regimens have been used to reduce adverse events and improve quality of life, but efficacy benefits have yet to be demonstrated. So the good news is more and more targets are becoming evident in metastatic colorectal cancer, and more targeted agents that essentially fit those targets have been developed. That includes immune therapy and MSI-high, HER2 target therapies and ERBB2 amplifications, KRAS G12C inhibitors with K12C mutations, and BRAF inhibitors with BRAF mutations, and others, of course, as well. And what we know is if we find the target and we have an agent that goes after that target, that the likelihood of a higher response and improved PFS is pretty significant. But unfortunately, only 10 to 20% of patients with metastatic colorectal cancer will have a target that is valid and then has a targeted agent that essentially locks onto it. So for 80+% of our patients with metastatic colorectal cancer, they do not have the option of molecularly targeted therapies or specific alterations to go after. And in their second and third line, we'll find ourselves in a situation where we have to think, and that's if a patient got exposed to FOLFOXIRI, it's becomes second line actually. But if a patient, got sequentially through FOLFOX and FOLFIRI, or FOLFIRI and FOLFOX, without any biomarker directed therapy potential, then those patients will find themselves essentially in second or third line, needing one of 3 agents: fruquintinib, regorafenib, or TAS-102 plus minus bevacizumab. Now, in the NCCN guidelines, these are all included in one box, because they've never been compared head-to-head, and therefore they're all valid options to consider beyond third line. And I think one cannot but overemphasize the importance of working collaboratively with a team of nurses, pharmacists, nurse practitioners, all revolving around the patient care. That's the patient care team model. Why? And especially as we get in later lines, but at any line, frankly, of therapy, is to ensure that the patients are getting the right treatment for their disease, that the toxicities are managed, that the doses are taken appropriately, and especially when we think about flexible dosing. And importantly, is also managing toxicities in between visits remotely through phone calls, assessments by the pharmacist or the nurse. And it's important also to keep in mind that not only patients need that education, but their caregivers as well. Very importantly, the Colorectal Cancer Alliance has a number of resources that are incredibly useful to share with patients. I've done that multiple times, and my patients are very appreciative and find them incredibly useful. So please make sure that as part of the shared decision-making, which is critical to help patients navigate through, that use the Colorectal Cancer Alliance resources to share with your patients and help with their management. So now moving on to module 2. So revisiting our treatment approach in metastatic colorectal cancer with expert guidance on adequately sequencing multi-kinase inhibitors in advanced disease. So let's start with a patient, Mitchell, who has metastatic colorectal cancer, who at initial presentation had good organ function, performance status of 1, a RAS mutation, that's a non-12C. So first line received FOLFOX and bevacizumab. After 5 months, was switched to capecitabine and bevacizumab. And then second line received FOLFIRI and bevacizumab and now progressed. So how would you approach sequencing therapy for this patient? So let's review the evidence in the next segment. So many drivers for first-line treatment remain valid in later lines of therapy. So tumor characteristics, of course, are important. The burden, the localization of the tumor, biology, meaning how aggressive has been the progression of the tumor and the symptoms, and then, of course, understanding clearly the RAS, BRAF, and mutations, and HER2 amplification status and MSI status. Age is important, performance status is important, organ function, comorbidities, attitude, expectations, and preferences, personal preferences, family preferences, and others are patient characteristics that are key as well. Treatment characteristics, prior toxicities with other regimens, so cytopenias, hand and foot syndrome, flexibility of treatment administration. Some patients want to detach themselves completely from intravenous therapy, socioeconomic factors, support, and of course, quality of life. So the first agent that actually came to us in third line plus was regorafenib through the CORRECT study, which compared to placebo at the time showed an improvement in both overall survival and progression-free survival, and was approved at the dose of 160 milligrams a day for 21 days, followed by 1 week of rest, so every 28 days. The next agent to be approved was TAS-102, which was compared with placebo in a study called RECOURSE. TAS-102 is a cytotoxic agent, a fluoropyrimidine, that's specially equipped to function beyond capecitabine and 5-fluorouracil. And TAS-102 was superior to placebo, both for survival and progression-free survival, again, with ranges that are very similar to what we've seen with regorafenib through the CORRECT trial. So before 2023, and with or without oncogenic drivers, we had a third line and a fourth line option that includes TAS-102 and regorafenib. And the question, of course, has and remained how to best sequence the two, TAS-102 first or regorafenib first. Well, most of the evidence we have today comes from real-world evidence. We'll speak about one, but there'll be others that suggest that essentially there's quite a bit of flexibility in sequencing. Then the question of continued VEGF inhibition, understanding that regorafenib does target partially VEGF, and then we'll see another agent called fruquintinib that does the same, that appears to continue to benefit patients. So VEGF inhibition makes sense across multiple lines of therapy. So the phase 3 Sunlight study looked at adding bevacizumab to TAS-102 and did show that TAS-102 plus bevacizumab is better than TAS-102, both for overall survival and progression-free survival. Important to note, however, that this study has significant limitations in terms of applicability to our practice in the United States and even in many parts of the world. And the reason for this is about 28% of the patients who received TAS-102 plus bevacizumab did not get prior bevacizumab. So that's unlike the practices in the US and many parts of the world, where bevacizumab is received in the first line and oftentimes is received in 2 prior lines of therapy sequentially. And in this study, even less so. And many did receive it in second line, not in first line. And when you actually separate the groups with prior bevacizumab exposure versus those without prior bevacizumab exposure, the biggest benefit for the addition of bevacizumab to TAS-102 was in patients who did not receive prior beva, although the benefit remains for those who did receive prior beva, but it's less clinically significant. So that essentially brought bevacizumab and TAS-102 into the third line. This was a third line only study for metastatic colorectal cancer with no oncogenic drivers. Another agent that essentially became available for our patients with metastatic colorectal cancer in the refractory setting was fruquintinib. Fruquintinib is a particular agent. It's highly potent and selective for VEGF receptor inhibition. It hits 1, 2, and 3 and has very little other kinase activities, unlike regorafenib. So fruquintinib was looked at first in FRESCO, which led to its approval in China, and then FRESCO-2 is the worldwide study that looked at fruquintinib essentially in refractory metastatic colorectal cancer, showing an improvement in overall survival. As you can see here, a significant hazard ratio of 0.662. Also, the PFS value was improved significantly with fruquintinib versus a placebo, with a p-value, pretty impressive hazard ratio of 0.321. I mean, for this level of refractory patients, with a p-value of 0.001. Now, what's interesting is when we looked at essentially fruquintinib, both from FRESCO and FRESCO-2, when we look at the individual patient data, and including patients who were either TAS-102 and Rego naive, or those that essentially were pre-exposed to TAS-102, Rego, or both. Now, as a reminder, FRESCO study excluded TAS-102 and Rego, and that's the China-only study. The study, FRESCO-2, did include a requirement to have exposure at least for one of the two, and about 40% of the patients received both TAS-102 and then or regorafenib in different sequences before they received fruquintinib. Well, the good news is that it did not appear that prior exposure to TAS-102 or regorafenib changes benefit from fruquintinib. So fruquintinib seems to work before as well, but also works well after TAS-102, after regorafenib, or after both. And that allows for further flexibility in the decision-making process when approaching patients with the idea of going through this line of therapy. So now, when we look at the algorithm, and we're thinking now third, fourth, and fifth line, which is great. Now we have more options for our patients. So looking at patients with or without oncogenic drivers after 2023, so with no oncogenic drivers, or starting with TAS-102 and bevacizumab for most patients. However, I would say that there's a level of flexibility. For some of my patients, the decision is to proceed with either fruquintinib or regorafenib prior, because the patients do not want to have any further IV therapy, meaning the bevacizumab. For that, TAS-102 would get deprioritized, and fruquintinib or regorafenib would go first. So now we have TAS-102 beva for most, followed by fruquintinib or regorafenib, and then regorafenib or fruquintinib, not in that order. For those with, of course, oncogenic driver, let's say with G12C, so adagrasib and cetuximab would be one example. that could come before or after. My preference would be for before TAS 102 and beva, but I think, it's reasonable to do that. And then, again, it's a dealer's choice after that. I mean, when we look at all the studies that we have on hand, whether regorafenib, TAS 102, beva, or fruquintinib, what we can see is, and I'm just putting those that are relevant, and we'll have a quick discussion about what redose means, the dose optimization strategy for regorafenib and the data that got generated from it. But when we look at a redose FRESCO-2 or Sunlight with prior beva, because that's the one applicable to our patient population, what we can see is that although with Sunlight, the patients were less pretreated, so you would consider those a more favorable subgroup of patients. Overall, the numbers look very similar across the board with regorafenib, fruquintinib, or TAS 102 plus bevacizumab. And I think that's important to keep in mind, as the data right now, and that's one of the main reasons why NCCN guidelines put all these three options in one box. There's really no preference for one versus the other, as all three appear to perform relatively well, or relatively modestly well, I should say, in the refractory setting, but in similar fashion. So now let's go back to our case. Patient with metastatic colorectal cancer progressed on 2 regimens based on the current evidence and guideline recommendation. What treatment option would you consider next? RAS mutation, non-G12C, prior FOLFOX, prior FOLFIRI, both with bevacizumab. So in terms of trying to understand the sequence of sequencing of agents, all what we have on hand right now is real-world evidence. So we did look at sequential treatment with regorafenib and then TAS 102 plus minus beva. This is called the STAR-T study, now published. And for this study, we essentially looked at a large database of patients in the United States of America, and in 2 times periods, and allowing us to look at both TAS 102 with or without bevacizumab and regorafenib. What we've shown in the study is when you look at time to discontinuation, which essentially is a surrogate of progression-free survival, what we can see that if you start first with regorafenib followed by TAS 102, you may have slightly longer time to the treatment discontinuation than if you start first with TAS 102 and rabo. But overall, the numbers appear to be relatively similar, telling us that there is no preference, even when adjusting with bevacizumab, telling us that there's probably not much of a preference between starting with one or the other, at least in this real-world data. And the same with survival. As you can see, the survival curves look very close to each other, and therefore, again, telling us that there is not much of a preference of starting with one versus the other. So rego, TAS 102 plus minus beva, or TAS 102 plus minus beva followed by rego. So moving on to module 3, a team-based personalized care in metastatic colorectal cancer, now addressing the practicalities of treatment delivery with multi-kinase inhibitors. Now going back to our patient, Mitchell. So the patient here was initiated on 3rd-line regorafenib. So what findings can we apply from recent studies pertaining to treatment dosing and scheduling and how to optimize the dose? So we know that with regorafenib, dosing that was used originally based on the correct trial with 160 milligram daily, days 1 to 21, that there were significant toxicities that essentially were prohibitive for many patients, and actually many patients were not able to continue their treatment, and this certainly made it difficult to apply this dose, and many different iterations of this dose were used by practicing oncologists, but there was no data to suggest that this is feasible or reasonable until we did the redose study, which is the regorafenib dose optimization study. And what this study essentially was looking at is escalating the dose of regorafenib from 80 to 120 to 160 as tolerated on a weekly basis during cycle 1, so 21 days out of 28 days. So week 1, we start with 80, then progress to 120, then 160 as tolerated by the patients. And this was compared to the standard dosing of the time, which is 160 milligrams per day. We had a second randomization, actually a primary randomization, I should say 1:1 to 1:1, which looked at giving a preemptive steroid cream, clobetasol, versus reactive. And the hope is that this will cut down significantly on the risk of hand and foot syndrome reaction. So the primary endpoint for redose was essentially the percent of patients who are able to get to cycle 3 and start cycle 3. So what does that mean? That means essentially the patients tolerated their maximal dose well enough to make it to cycle 3 and continues through cycle 3, but also have disease control to be able to make it beyond cycle 3. And so indeed, with the dose escalation strategy, so 80 to 120, 160, there was a superior outcome, allowing more patients to make it to cycle 3 and beyond versus those that went on 160. But that also translated into what appears to be, although a secondary endpoint, but what appears to be an improvement in overall survival, went from 6 months, which is what we've seen with Correct, to close to 10 months with the dose escalation strategy. So that was a positive for the patients. And what we've noticed when we look at patient-by-patient dose modifications is that, well, for about 40% of the patients, we were able to achieve the 160 milligrams, so the maximal intended dose. But for other patients who were able to go beyond cycle 3, 30% continued with 80 milligrams and another 30% with 120 milligrams. So this is an example of flexible dosing strategy. There are other studies that looked at the same, either real-world evidence or a European study called Challenge, and that's Rearrange. And those studies essentially did suggest about the same, meaning that flexible dosing with regorafenib appears to lessen toxicity while providing flexibility. Now, when we look at essentially the toxicities, the dose escalation strategy was more tolerable, and it did appear to maintain quality of life compared to the 160 milligrams, meaning that patients who actually received 180 to 120 to 160 as tolerated appeared to have maintained their quality of life, had better exposure to regorafenib and better toxicities and better quality of life than those who essentially ended up on the 160 milligrams. And we hold the standard dose back at the time of the study, but now with inclusion in both the NCCN guidelines and the ESMO guidelines, the standard dose is frankly the dose optimization dose and not anymore the 160. So now going back to the case, to the patient that essentially failed FOLFOX-BEVA, FOLFIRI-BEVA, and then initiated on third-line regorafenib. So in this case, again, and following the multidisciplinary model, the pharmacist explains the regorafenib dosing schedule to the patient and the family, 80 to 120, 160, along with the nurse coordinate with the patient to establish the next dosing level. So in my practice, the pharmacist and or the nurse will be calling the patient on a weekly basis, at least in the first cycle or and occasionally into the second cycle, to ensure that the patient is taking the right dose. In the first cycle, of course, the importance of escalating and with assistance from the pharmacist and nurse coordinator and the nurse. And then final counseling provided by all team members, with nurses, pharmacists leading the discussion of anticipated toxicity. Our advanced practitioners, so nurse practitioners and PAs, take this at a high level as well. So when we think about the management of these adverse events associated with regorafenib, there are a number of these toxicities that are agent-specific, hand and foot syndrome reaction. I think very important before starting the treatment is the examination, do any manicure, pedicure to remove any hyperkeratotic skin, and advise the patients to avoid friction stress on the skin. Supportive measures as indicated. For hypertension, of course, pre-existing hypertension should be controlled before treatment initiation. And with fatigue, important to keep gentle exercise, thyroid replacement if hypothyroidism, and other interventions as listed here. Now, this patient essentially went on redose, and the redose strategy was appropriate for this patient. But let's assume that the patient presents ultimately back to you with a grade 2 hand and foot syndrome reaction. So how would the team manage this event? With a grade 2 hand and foot syndrome reaction, you would stop regorafenib and treat with steroid cream. You skip week 3 dosing, and you restart at a lower dose until the toxicity resolves. Well, the good news is that there are strategies to mitigate hand and foot syndrome reactions, and we've examined those with a regorafenib dose optimization strategy, so redose study, with looking at preemptive clobetasol. And frankly, you can use any steroid cream. It doesn't have to be clobetasol. Clobetasol has some particular properties that perhaps favor it, but you can use any over-the-counter steroid cream. And preemptive clobetasol did seem to lessen not just the rate, but the grade of hand and foot syndrome reaction compared with reactive strategies. And therefore now for all my patients, before starting them on regorafenib, I actually start them on steroid cream. In fact, I do the same with fruquintinib, although the risk of hand and foot syndrome reaction is much lesser, but I still try to do that, especially for patients who are older, when I'm concerned about some social support. With TAS 102, your biggest concern are actually neutropenia, leukopenia, and anemia. They tend to occur in the first month or two. In fact, about 4% of the patients will have febrile neutropenia and may need to be admitted to the hospital. So keep that in mind, especially with patients who've had issues with bone marrow toxicities previously. So there are certain clear guidelines about how to best address adverse management and dosing with TAS 102 with or without bevacizumab that are specific either to TAS 102, meaning bone marrow toxicities or cytopenias, and with bevacizumab, of course, the most common would be hypertension, and how to best manage this. So what are the take-home messages for team on later lines of therapy with metastatic colorectal cancer? Or one, that effective therapy is available for later line management of metastatic colorectal cancer. So we do have agents such as regorafenib, fruquintinib, and TAS 102 with or without bevacizumab. And these are validated options which have proven to have improved survival, improved PFS, improved outcomes for later lines of colorectal cancer management. And so what we know and what we've always known is that when patients are exposed to multiple lines of therapy, we do tend to see significant improvements in their survival, meaning all available agents should be made available to the patients if it makes sense for the patient, of course, because that's how you maximize their opportunities to survive. Now, patient choice, tolerability, quality of life are important factors to consider when developing treatment goals for later lines care. Considerations such as patients' preferences for oral versus IV, the toxicities with previous regimens, the patient's aversion to further lines of therapy. I think all these are very important options to discuss with the patients and the family as part of their whole care. Now, one cannot but overemphasize the importance of actually having the whole team care for the patient. It's very complex care. A lot of the patients may not have enough support, but also, many of our patients have to travel distances to come to us and get treatment. And so whether using telemedicine, at least in between visits, having oncologist pharmacists, having our nurses and other team members, nurse practitioners, follow through with the patients to make sure that the patients are following instructions, help adjust dosages as indicated, be aware of evidence-based dosing strategies to deliver effective care with a lot of these agents, help our patients stay on treatment and mitigate toxicities. One example is regorafenib dose-optimized strategy with essentially 80, 120, 160 in the first cycle, or even with TAS 102, where we're finding essentially bi-weekly TAS 102 instead of 2 weeks on, 2 weeks off, to be much more tolerable and lessens the risk of cytopenias. So thank you for joining and participating in this educational program on metastatic colorectal cancer. Please remember to download the practice aids and resources from the Colorectal Cancer Alliance to share with your patients. I hope you found this session informative and useful for your practice. Thank you again.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Colorectal Cancer Alliance. This activity is supported by an educational grant from Bayer HealthCare Pharmaceuticals Inc. To access all materials for this activity, visit peerview.com/WEP860.